Please take the roll.
Director Bott?
Here.
Director Curry?
Present.
Vice Chair Deere? Is absent. Director Garza?
Present.
Director Harrington? Is absent. Director Kim?
Present.
Director Ryder?
Here.
Director Robinson? Is absent. Director Sorrell?
Present.
Director Story?
Present.
Director Webster Cross?
Present.
And Chair Taylor?
Present.
You have a quorum.
Thank you. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all actions. To streamline, we'll combine the actions into a combined motion. Meetings of the CCH board and its committees will be held remotely until otherwise noticed due to the determination that a public health emergency exists. Because the public health emergency is due to expire May 11th, and the governor's emergency proclamation that allows for meetings to be held remotely is not expected to be renewed at the beginning of May, meetings of the board and its committees will begin in-person meetings starting in May. The next regular meeting of the board will be held on Friday, May 26th at 9 a.m. The first item on today's agenda is employee recognition, which will be reviewed by, I believe, Ms. Valerie Amos. Is that correct?
Good morning, everyone. This is Valerie Amos, CHRO. I am happy to share the announcements on behalf of Mr. Rocha. Next slide, please. So we're pleased to share some new hires. As mentioned at one of our previous meetings, I think you may have met Donica Austin, who is our Chief Hospital Executive for Stroger Administration. Priscilla Cabrera, who's Patient Access Manager for Provident. Anthony Drew, who is a member of our team in HR. He's our Operations Counsel for EEO. Teresa Matuch, who's our Laboratory Services Manager for Clinical and Anatomical Services. Kathleen Minogue, who's our Director of Maternal Child Health and in Nursing Administration. We have Destiny Moore, who's also our Behavioral Health Program Manager for County Care. Latrice Porter Thomas, who's our Director of Life Safety in the Safety Department, Cindy San Miguel, who's our Director of Equity in Health Plan Services, and Dr. Robin Singh, who's our Chief Operating Officer for Health Plan Services. In terms of our promotions, we are very proud to share that David Allen is now our Director of Finance for Medicare and Medicaid for County Care. Ratna Kanumara is our Associate Chief Strategy Officer for Strategic Planning and Implementation. Keisha Love is our Director of Health Information Technology for Health Information Systems. Ian Pino is our Manager of Transitional Care for Community Care Coordination. Patricia Rayborn is our Director of Critical Care for Nursing. And Deidre Watts is our Comptroller for CCH in the Finance Department. Please join me in congratulating all of our promotions as well as welcoming our new hires. Thank you. In terms of further recognition, congratulations to Dr. Claudia Fegan, Cook County Health's Chief Medical Officer, for her recognition in Becker's Hospital's reviews, 149 Black healthcare leaders to know, list for 2023. The individuals highlighted on this list are leading top healthcare organizations, fostering positive patient experiences, paving the way for the next generation of leaders, and promoting health equity. Congratulations, Dr. Fegan. Congratulations to Ling Dang, Cook County Health's Chief Experience Officer, for being recognized by Becker's Hospital Review as one of the 50+ health system chief experience officers to know in 2023. Chief experience officers balance the best interests of caregivers, patients, and leadership to improve and continue to deliver excellent care and patient experience at their organizations. Congratulations again, Ling. Congratulations to Dr. Lily Hussein, oncologist, for being recognized by the American Cancer Society at their Researchers event. The event celebrated the work women are doing in cancer research. Dr. Hussein participated in a panel discussion on the evolution of cancer care and then was honored for her more than 50 years of service at CCH. Congratulations again, Dr. Hussein. The CCH, two CCH employees have been chosen to be part of the Getting to Zero GTZ Illinois Community Advisory Board. The GTZ Illinois CAB will meet to provide meaningful input to partners as they work to implement the GTZ Illinois plan to eliminate HIV/AIDS transmission in the state. Dee Dee Lehman is one of the lead peer health navigators at Austin CBC program. She provides patient navigation for newly diagnosed patients, PREP navigation services with the Prevention Health Education team, and is a certified HRV tester. Lonnie Rowden is a consumer development and advocacy coordinator for Cook County HIV Integrated Program, CCHIP, where he serves as the chairperson for CCHIP's Joint Advisory Board and is the staff liaison for Core Centers Advisory Board. He facilitates healthy lifestyle programming for CORE's Healthy Aging Initiative, CHAI, patients over 50+ years of age. Congratulations to both of them. Next slide, please. We held our Patient Safety Week during the week of April 17th, where we had a really outstanding speaker, Dr. Brian Sexton, who spoke on resilience. In addition to that, we had fun, games, and giveaways in our cafeteria. All of these efforts were led by the patient safety team under the direction of Dr. Eric Makaitis, our Chief Quality Officer at the organization, and his team. So in addition to all of that, we held a poster presentation. There were over 50 posters submitted for Patient Safety Week, and here are the winners. And they are under 4 categories. The first category is Best Team Project. For first place, Commit to Sit. Second place, Expanding Overdose Prevention Tools at CCH. The ACHN Naloxone dispensing project. Most innovative, first place was REPLI, an innovative and client-centered digital family planning tool. Second place was improvements in the rates of health risk screenings. Congratulations to both of these. The third category was most impactful, which is first place, improving throughput, LWBS. Second place was stroke. The fourth category was audience choice. First place was achieving perioperative patient safety in operating room through collaboration, communication, innovation, and active involvement of patient and family. Second place was safety, number one priority. Pre-op checklist makes it easy. So congratulations to all of the poster winners. This was a great opportunity for our organization. Thank you, Dr. Makaitis, and your entire team for promoting this. Next slide, please. Next slide, please.
Valerie, it's Deb. I believe that is the end of the
Okay.
employee recognition.
Okay, great. Thank you.
Thank you very much, Valerie. Appreciate it.
No problem.
And congratulations and hats off to all those for your continued achievement and contributions to CCH. The next item is public testimony. Madam Secretary, do we have any speakers who registered to provide virtual oral testimony?
We do. We have one registered speaker, and before I get to that, for the record, directors Harrington and Robinson have joined us.
Thank you. Thanks for acknowledging that.
Just a reminder to the public speaker, you have 3 minutes to provide your testimony. I'll give you a reminder when you have 30 seconds remaining, and then when your time is expired. The first speaker is Lenny Asaro. Mr. Asaro, would you like to begin?
Yes, can everybody hear me?
We can, thank you.
Thank you, good morning. My name is Lenny Asaro. I'm a partner at the law firm of Fager, Jinker, Biddle, and Reith. Dear Chairman Taylor and all members of the Board of Directors, I would like to seek clarification regarding Cook County Health and Hospital Systems policy in reference to offshoring jobs to India. Based on addendum number 1 for a request for proposal number H21-0026, titled Revenue Cycle Provider, there is a request for 250 full-time equivalents to support end-to-end revenue cycle. The RFP was written in a way that the vendor selected would be allowed to provide support for the front end, middle, and back end without Cook County Health and Hospital Systems having to write another RFP for the different services. In my review of the request for 250 FTEs, and based on Cook County Health and Hospital Systems response, which was a yes to the question, quote, will offshore resources be allowed on this project, close quote, I would like to ask, when did Cook County and Cook County Health and Hospital Systems agree to offshore 250 jobs to India via the Guidehouse contract? Guidehouse is a company. If offshoring of Cook County jobs is going to be the norm, how does this impact union members? In other words, if a paying union member leaves the county, will their job be offshore to India? I realize that some of your technology vendors may be using offshoring to provide specific technical support for a system. However, this RFP is service-based and does not require technical support for any type of technology. Question: with many overseas countries continuously looking at ways to impact the US government, how are the security risks associated with offshoring being addressed? In other words, is the Cook County Health and Hospital Systems network connected to the Cook County network? If someone launched a cyber attack offshore on the Cook County Health and Hospital Systems network, would it impact Cook County as a whole? Second of the third question, if offshoring union and non-union jobs are going to be the norm for Cook County, what other jobs have been identified for offshoring? Final question, or second last question. Based on the broad scope of the RFP, will Cook County Health and Hospital Systems be in an ongoing approval mode for increased services provided by the company known as Guidehouse, without Guidehouse having to present the request to the board for approval? Or will continuous contract amendments with increases be the standard? Final question, because this is a service-based multi-year contract, how has Cook County Health and Hospitals Systems provided system access and enforced the requirements for having to date vaccine, badging, security, etc. for the offshoring staff. And I just finally respectfully request that this letter that I published from that we provided to you yesterday be admitted in writing into the record. Thank you very much for your time and your patience for listening.
Thank you. As a reminder, written testimony will not be read in the record, but it will be included in the official record of this meeting and posted to the website. Following receiving any oral testimony, Madam Secretary, can you read the list of names of those who submitted written testimony into the record?
We did not receive any separate written testimonies besides Mr. Asaro's, which will be included in the record.
Thank you very much. Appreciate it. The next item on the agenda are the board and committee reports. The minutes of the March 31st board meeting are being presented for your approval. Approval will take place in the combined motion later in the meeting. Are there any corrections or revisions needed to be made to the minutes? Thank you. Hearing none. Next, Director Garza and Valerie Amos will review the Human Resources Committee metrics. That committee did not meet this month, so the metrics are being presented directly to the board.
Okay, good morning, and not sure why I'm not able to come on camera, so I'll work on that. But in the meantime, the Human Resources Committee did not meet this month. The next regular meeting is scheduled to be held on Thursday, May 18th at 12 p.m. The committee is due to present metrics, so Ms. Valerie Amos, our Chief Human Resources Officer, will review the metrics today with us. No motion is needed. The metrics are presented for informational purposes only, and I will pass this over to Ms. Amos. Thank you.
Thank you so much, Mr. Garza. This is Valerie Amos, Chief Human Resources Officer. The slide before you shares our hiring results from fiscal year 23 through the end of March. So December 1st through March 31st, we have filled 512 positions. Please note that this does include both internal transfers, promotions, as well as externals. So we are continuing to track and trend this on a monthly basis. There's an 82% acceptance rates for our offers, so that's still a very positive rate. As you can see below in the linear graph, we have depicted quarter by quarter the number of hires and filled positions, and we will continue to track that. In terms of the external hiring velocity, 330 positions out of the 512 represent external hires, so new joiners to the organization. And so we're excited to continue to track that number as we continue to improve on a monthly basis. The time to fill, which is the posting date until someone is hired into the position. We are proud to share that this particular metric has gone down. Our goal is less than 90 days. And we are at 85 days as of this time period. 92 days for nursing. Our goal is to decrease that metric to 45 days or less. And then the external is 102 days. So we still have a ways to go, but we are trending in the right direction for our time to fill metric. As you can see in the linear graph, we've both depicted the quarterly results as well as the external results. Next slide, please. Here's another depiction of the individuals who have started with the organization. On the previous slide, I noted that there were 512 individuals who had accepted offers or made movements within the organization. So of that 512, 494 people have actually either moved into their positions or joined the organization. So this is a year-over-year depiction of those results. And so as you can see, we are by far, exceeding the previous 2 fiscal years. The bottom graph also depicts the number of individuals who have actually started. So as I mentioned, there were 330 externals. Of that, 299 people have started with us during this period of time. Next slide, please. So in terms of our separations and our turnover, we still are at 4% in terms of our turnover, which is very admirable in the market. We are, double digits nationwide. So our separation numbers continue to trend down. So we're very excited about that. But please do know, really, we are a little over 100 in terms of our growth within this time period based on our number of separations as well as hires. So you're going to see that in the next slide. The depiction again with the number of individuals who have exited the organization. Year over year, we see that this particular time period in this fiscal year represents 222 individuals who have separated from the organization. As noted in the dark blue bar, that represents our first fiscal year. I'm sorry, a fiscal quarter rather. And the green, which is 57, represents this particular month of March. So overall, we still are, trending downward, which is great. Down below, we see the top reasons are retirement and resignations. In the dark blue bar, for this particular time period, resignations have exceeded our retirements. We are continuing to track and trend, but as I mentioned before, we have a slim margin. As we continue to accelerate hiring, we will continue to do that based on our monthly job fairs and our support with our external vendors to refine our processes to really make some strides here because we are continuing to see separations from the hospital. So I want to be, crystal clear that we will continue to make notable efforts as we look ahead at our forecasted retirees. Next slide, please. Our turnover is depicted year by year in this particular slide. As I mentioned, we're at about 4% total. However, we are trending a little bit less in terms of our turnover, as mentioned before. Next slide, please. The pre-pandemic turnover, I think that this was one of the questions at a previous meeting. There was a question, how were we looking pre-pandemic as it related to separations and turnover? And so this is probably more information than needed. However, the team was able to pull information prior to me starting. FY18, as you can see, it was 3.1. And then, of course, during the pandemic, there was 3.1% as well. So it remained flat in terms of the turnover percentage. We saw some acceleration in our turnovers after the pandemic hit, which is probably the same curve as we would see in the market with the great resignation, the separations and reshuffling. People had choices and decisions to make during that time. So this does not represent anything different from the national market. So I hope that that answers the question from the previous meeting. Next slide, please. I will take questions at this moment.
I
Thank you
have a
so
question.
much. Yes.
Previously, I asked a question with regard to the retirees. Is
Yes.
there, and there was information that was given that helped me understand the process, and I recognize it's not easy. My question is, are we able to put together a package that could attract the retirees from other organizations? Because they'll bring a certain set of skills that would be appropriate, and it would also maybe alleviate some of the anxiety associated with the travel folks. Yes, they're going to come in at a higher rate, but at least they're coming in and the questions surrounding competence could possibly be answered.
So that's a really good question, and it's something for us to take back. We are certainly looking at many ways, Director Robinson, at attracting talent throughout the organization. And so we have been exploring, as you mentioned, the retirement process, and there is some legislation around it. However, that's one of the many ways that we are looking to attract individuals back into the organization. Thank you for that
Right now,
question.
but notice the difference I said in case it was missed. The
Other
retirees I'm
organizations.
making reference to are not a part of our organization, so the legislation
Correct.
is no longer necessary. Okay,
That,
great.
that is correct.
Thank you.
That is correct. I believe it's correct. Yes, so absolutely. I mean, when we host our job fairs, we certainly look for targeted, nursing alums. We are connected with a number of nursing schools. We are connected with a number of programs, workforce entities as well. So that is certainly something that we have targeted, and we can be more formal and deliberate and intentional with it. Thank you for that. Director Story's hand is also up.
Thank you, Valerie.
Sure.
Yeah. It seems somewhat paradoxical that, we have such a low turnover, which is just, I mean, I guess when you look around the country, we're probably best practice, 4%. I mean, that's just tremendous, but it's a head scratcher at the same time for me, knowing that, like I said, it's not a question as much as is, I know it's a challenge for y'all. We have just such low turnover rate, but yet the onboarding process is still, this slow pace, people being onboarding, not so much onboarding, but coming to an institution where we have such low turnover. I mean, I just can't wrap my brain around. That's why I said somewhat paradoxical for me when I look at these low turnover numbers. And yet people are not standing at the window saying, let me in, I want to work for you. Anyway, just a comment, not a question. Thank you.
No, I appreciate that. We've hosted, as I mentioned before, monthly job fairs. We have a really good cadence. We do see a number of candidates who come out, and we have, of course, minimum qualifications that we must abide by. And so there's a lot of enthusiasm, I think, again, with the support of everyone within the organization, sharing with their networks our job fair information. It's going to continue to drive those numbers up. And we're hopeful that when we get to the 100 number, we, are able to hire 80 of those individuals. So we will continue our process. And you're right, these are still very challenging times, and it will take us, several years to truly see the impact, probably nationwide, in terms of driving the workforce to where we were pre-pandemic. Director Curry, I see your hand.
Yes, good morning. Thank you, Ms. Amos. This is somewhat connected to Director Story's observation. So there's a lot of positive movement that's occurring across the board in these different functions. But the one, and if I missed it, I apologize, the one metric that I think is critical here, what is the current overall vacancy rate that we have? Is it better, the same, or worse at a point in time last year? Because everything seems to be trending positive, and I guess it would be important to know what that vacancy rate, total jobs that we have available or employed versus those that are open. I haven't seen that particular metric anywhere. Do you know off the top of your mind, one, whether it's been improved, the same, worse, or a number or a percentage that you could share with us?
Sure. First, I could share the employee base. Then I can also share the vacancies. Debbie, can you go back a few slides, if you wouldn't mind? We're a little over 5,600 employees.
Yes.
And if you can notice, year over year, we continue to lose individuals. Go back one more, this slide. Oh, sorry. So this particular slide, Director Curry, represents the number of employees at the end of March. So we were at a little over 5,600. But the reason the slide is so impactful is because, as you can see, back in FY21, we had over 6,000 individuals. So to answer your question, we were trending on a negative path when I started, and I would assume probably, prior to me starting, I can't make that assumption based on the slide. However, it took us some time to start kind of, trending upward. So our vacancy number, unfortunately, hasn't really changed to show the impact of all of the great work that our teams and external vendors have brought to our organization. So we are still trending over 2,000 vacancies because as we hire, we continue to see the separations. So that's why, again, I think that we're starting to trend, month by month. We are probably in our sixth consecutive month that we have now seen the trend of moving external hires above the number of separations, which is why it's so critically important to see that number. So this particular fiscal year, from 12/1 through March 31st, we have brought aboard, or we have hired externally 330 individuals, but 222 of those separated. So that still leaves a narrow margin, but at least we have a net gain. Does that answer your question?
Yes, it does. Would it be possible going forward, if it makes sense, to report? I guess I'm looking for the one number that's a vacancy rate because it's relative to whatever that base happens to be as that
Sure.
moves in terms of total employees. What is that percent, one point in time to the net?
Gotcha.
So that would be
Yeah.
helpful going forward.
Okay.
Thank you.
Sure, I can add it. No problem. Thank you.
Appreciate it.
Any other questions? Director-
Or your hand still raised? I don't know if that's different or not.
Thank you.
Director, is that any further questions, directors? Okay, thank you very much. Next, Director Harrington will now review the Audit and Compliance Committee meeting minutes. Director Harrington.
Thank you, Chair Taylor. The Audit and Compliance Committee met on Friday, April 21st at 9 a.m. The next regular meeting of the Audit and Compliance Committee is scheduled for Friday, June 23rd at 9 a.m. Nicole Amaral, Chief Corporate Compliance and Privacy Officer, provided her report, which included an overview of the following action items presented for the committee's consideration: the 2023 County Care Compliance Plan and the 2023 County Care Fraud, Waste, and Abuse Plan. Following Ms. Amaral's report, Tom Schroeder, Director of Internal Audit, provided his report, which included an overview of the proposed internal audit that was presented as an action item for the committee's consideration. The committee recommended approval of all three action items. The committee did go into closed session to receive closed meeting reports. A brief summary of that information will be provided later when the board goes into closed session. Because there are no action items associated with closed session, the minutes can be included in combined motions for action items later in the agenda. And that concludes my report.
Thank you very much. Next, Director Curry will now review the Managed Care Committee meeting minutes.
Okay, good morning. The Managed Care Committee met on Friday, April 21st at 10:30 a.m. The next regular meeting of the Managed Care Committee is scheduled for Friday, July 21st, 2023 at 10:30 a.m. There was a report on our health plan services presented to the committee. It was reviewed and the report was discussed, which included information on the following subjects. There was an introduction of the presenters, key metrics and objectives and key results, including redetermination data and strategies. There were also reported the strategic initiatives and priorities, which included member rewards program, member vaccination, chronic kidney disease program, flexible housing pool, addressing domestic violence, and food care. Of note, during the discussion of the flexible housing pool, it was reported that 54 county care members are housed as referenced in the presentation pertains to our investment that we've made. There are over 1,000 individuals who have been housed in general, via the flexible housing pool. There is some additional funding through ARPA for an additional 100 beds for the system. 25 of those will be for county care members. More investments are needed, and until we're able to sustain the program and look at it as the benefit for which it is and determine how to tie it into the Medicaid service and the Medicaid rates. During the discussion of the information presented on food care, Dr. Collins indicated that they would have preliminary metrics available on the success of the program within the next 6 months. That's a summary of the report on health plan services. If there are no further questions, approval of the minutes can take place later in the meeting in the combined motion.
Thank you very much. Next, Director Garza will now review the Quality and Patient Safety Committee meeting minutes. Director Garza? Actually, I believe that's Director Kim, is that correct? Hi, Garza.
I believe that's right.
Yeah, it should be Director Kim.
Actually, Chair Taylor, Director Garza filled in as chair for Director Kim. So I'm not sure who would like to present the minutes. I believe they both have the notes, but there may be a preference.
I'll defer. to
If
the
you don't
chair.
mind, Raul, Director Garza, would you mind go ahead and present the minutes?
Not at all. I wanted to make sure I was.
Thank you.
I wanted to honor your wishes. Sure. So let me just pull those up and great. Okay, thank you. The Quality and Patient Safety Committee met on Thursday, April 20th at 10:30 a.m. Please note that we are not planning to have any re-review of the metrics and presentations from the meeting, but if any additional questions are raised, the staff are certainly present and ready to address those questions. The next meeting of the committee is Thursday, May 18th at 10:30 a.m. The committee received the following reports, which are included in those minutes. The HRO dashboard. The committee reviewed metrics from the following HRO work groups: patient experience, clinical documentation, clinical outcomes, readmissions, throughput, and HEDIS. As a follow-up, Director Story inquired regarding the status of the equipment used for breast cancer screening. And Dr. Mikatis responded that he will look into the question and provide a response. We received regulatory and accreditation update, also included in the minutes. We received a quarterly nursing operations update, which again are included in the minutes. Received update from HRO, Dyad on patient experience. Received overview of the graduate medical education presentation with a proposed clinical training affiliation agreements, and then received the EMS and MEC reports. The Soldier Hospital and Providence Hospital Quality Committee summaries were presented for the committee's information, and their medical staff action items were presented for the committee's consideration. And all of those are included in the minutes. The committee approved the following action items, which are included in the minutes. Approved the Stroger and Providence Hospital medical staff appointment, reappointment changes. Recommended approval of proposed clinical training affiliation agreements. The committee did go into closed session, but we're not expecting to re-review that information. So the minutes are being presented for the board's consideration as part of the combined motion to be made later in this meeting. That concludes my report, Mr. Chair.
Thank you very much, Director Garza and Director Kim. I appreciate it. Next, Director Ritter will now review the Finance Committee meeting minutes. Director Ritter.
Thank you, Mr. Chairman. The Finance Committee met on Thursday, April 20th at 9 a.m. The next meeting of the committee will be held on Thursday, May 18th at 9 a.m. I noted is my daughter's birthday. No, we're not, as the other directors have indicated with their reports. I'm not planning to have staff re-review reports and contracts from the meeting. However, while you are reviewing the minutes, Deb will have a slide reflected with the list of the contractual requests greater than $1 million. If any additional questions are raised, Charles, Pam, and staff are here and ready to answer any questions. The committee considered the following action items, which are included in the minutes. Conditionally approved 47 contracts and procured
And so congratulations to our entire pharmacy team. Few of our distinguished individuals who have been recognized for America's Essential Hospital Fellowship. We want to congratulate Dr. Priscilla Augusten-Ware, who is the Chair of Correctional Health, Dr. Umar Jabbar, who is Attending Physician of Hospital Medicine, and Alex Normington, who is an Interim Chief Communications and Marketing Officer. for being selected to the America Essential Hospitals Fellowship Program. Being selected in our support of the Essential Hospitals Fellowship Program is building leaders to be future administrators across the organization, and part of the board's request to ensure that we're having continuity and resiliency in staff planning for the next generation of leaders across Cook County Health. For more than 30 years, the AEH Fellowship Initiative has been a highly sought after leadership program dedicated to educating participants on the issues that impact essential hospitals and provide the skills needed to lead strategically and advocate for resources that promote health of underrepresented and marginalized communities. Next slide. We also want to share with you a few system updates. Following up our strategic plan for this month, we wanted to note what we have been able to accomplish as part of our strategic plan. We wanted to share with you that we have approved the service expansion for Provident and ECH locations, vascular thoracic surgery, GI, gynae, and plastic surgery and pain specialists to be at our locations at Provident and across our ACHN locations. We also launched our Information Technology Steering Committee. County Care is using predictive analytics to enhance kidney disease and kidney disease detection. We've exceeded County Care membership utilization of Cook County Health Services revenue target for the first quarter. The Cook County Department of Public Health and IDPH vaccination program grant received for the state for $2.5 million. We announced this year's Providence Scholarship Fund. Fentanyl testing was implemented at our lab and is available across all of our points of care. 3 murals were unveiled as part of our partnership with the Cook County Health Foundation, and the CIRMAC launched its individual behavioral management plan program for severely mental ill population. Coming soon, we will be announcing a 100 Ideas for Change campaign. This is a campaign where every employee across our enterprise will be able to submit what idea they believe will be most impactful for change, for the improvement of our organization, our system, or care for our patients. In April, we will have job fairs for health plan services, pharmacy, CIRMAC, and nursing. The Cook County Department of Public Health will be conducting a workshop on building the community health worker workforce as part of the National Association of Community Health Workers annual conference. We will be awarding physician recruitment contracts in order to be able to increase and expedite our physician recruitment, especially in the primary care area. We will be having a specialty clinic process improvement for schedule, staffing, and access to make sure that patients will have greater access and availability and connectivity with their specialist physicians. We will have transfer agreement with West Suburban for ortho, vascular, and complex general surgery. County Care will be launching a domestic violence program, and we have our CIRMAC telemedicine phase 1 to roll out this spring and summer. That's a little bit of the initiatives to come forward. Any questions? I'll take a quick pause there. All right, hearing none. Next slide. We also want to just again highlight that we are currently having our second annual Providence Scholarship Program. We want everyone to know that our application period is open. It is open from April 20th to May 26th. There are a few divisions of scholarships, and we'll review those with you. We have our Health Professional Scholarship Program. This provides scholarships to medical, dental, and advanced practice providers attending a graduate level academic program. Students are eligible for an award of up to $20,000. We have an Allied and Undergraduate Scholarship Program. This provides scholarships to allied health and undergraduate students in select programs. Students are eligible for an award up to $10,000. Part of the eligibility requirements for the scholarship is that you must be a U.S. citizen permanent resident residing in Cook County. You must be a current student or enrolled in a qualified academic program at an accredited academic institution, have demonstrated financial need through FAFSA, and a GPA of 2.7 or greater, and in good academic standing. We hope that you will visit our cookcountyhealth.org for more information to apply, and want to take a special note to thank our Chief Human Resources Officer, Valerie Amos, and our Cook County Health Foundation for helping to put this scholarship program together for its second year and ensuring that we have a future generation of healthcare leaders starting all the way from high school on through medical school. What this program really represents is the opportunity for a Cook County Health resident from their first year of college in their undergrad all the way through their medical school to have almost a full scholarship program, because these scholarship programs are renewable through competition. And so that creates a full longitudinal pipeline where someone can get their entire medical education paid for through this program. And then we hope that they will want to join our organization afterwards, but that will be at their choice. So we are very excited about this program and what it will do for helping to bring equity and access to better educational opportunities for all individuals at Cook County.
Mr. Rocha, thank you for that and highlighting that. One question, and I see there are a couple of hands raised that I have. Is it required that the students attend schools in Illinois, or is this applicable if they're residents anywhere that they go to school?
So it is applicable that they're residents, that they go anywhere, but that they're Cook County residents, that they're residing at the time of their application.
Got it. Okay, thank you. I saw in order that I saw, I think was Director Story and then Director Kim. Director Story?
Thank you, Chair Taylor. Israel, thank you for noting the categories, including the high school students. As you said, this is a pipeline. This is a great program, starting with high school students all the way through allied health professionals to the postgraduate. I think it's an outstanding program once again. Gratitude to you and your team for driving this initiative from the high school all the way through to the healthcare professionals. I think it's just outstanding that all of our children have an opportunity from secondary, allied health, and postgraduate work to participate in this program. It's super. Thank you.
Thank you, Chair. And also cannot forget to thank President Perkwinkle and the Board of Commissioners for helping to seed the initial program and to get this started. And so this is really a reflection of their work and all of the Board of Directors for allowing this to move forward. So thank you to everyone. And we were very excited to start seeing those students trickle in, and had an amazing opportunity to talk to one of our first nurse graduates to complete. And she was very excited. And the proof of the amazing part of the program, she did incredibly well in her nursing programs and was a salutatorian of her class and helped to lead her class in several initiatives. So amazing things to come from these amazing cohort of students. Thank you.
Thank you. Director Kim.
Yeah, first of all, I just want to echo kind of the comments about this really amazing opportunity. I know it's really early, and you're heading into your second year cohort. And I'm just wondering if you have even any early interval data suggesting that these individuals may actually stay in Cook County or even enter our health system. I just think this is just a transformative opportunity for individuals. So thank you.
Thank you. So we are doing a wonderful opportunity that was the request from our board and was put into action by our Human Resources Department and our medical staff, that we're going to be actually having mentorship programs and data analysis. So once we get that first round from our first class, we'll be happy to come and celebrate with the board the wonderful things and the retention and recruitment that we're having here locally. As they're just going into those employment opportunities now, we'd love to come back and share that. But part of it moving forward is that they're going to be paired with mentors and clinicians so that they can also have that access to education through the entirety of the completion of their academic study. And we're going to stay close and working with them closely to make sure that we're there to provide whatever mentorship is needed.
Thank you. This is wonderful.
Director Bott.
You're on mute, Director Bott.
So thank you, Chairman. I want to echo those comments and say that I wonder if there's thinking as it relates to working with those FQHCs and other entities that serve county care members, where there might be a way to provide another pipeline development opportunity because in those spaces often there are folks that want to have it get more training and could be then potentially better for those members, but also have an opportunity to work with Cook County down the line. So that's a thought.
No, absolutely. Well, we would say and remind, it is open to all Cook County residents. So if you work at an FQHC and you're wanting to advance your studies and programs, we definitely encourage do to participate and to apply. We would love to sponsor any individual in Cook County who wants to be able to help become part of our medical corps here at the county. And so, and again, we always say it's at their election that they come back, not a requirement, but we really do hope that they will join the Cook County Health family when they finish. But they are available to enrich the community here at Cook County. And so we're just very excited to be part of that. We invite everyone to participate. And I think what we can do, Director, by following up your information, is we can make sure that we share the information with the FQHCs should they have any individuals who would want to take advantage of this scholarship opportunity. I think that's a great idea. Thank you. Well, no other.
A lot of comment questions. It's a great program. And so again, hats off to both, starting with, quite frankly, thanking the county president and commissioners and the staff here for getting this done, and also our foundation for actually continuing to raise capital for it and stuff.
Absolutely. Thank you. Next slide. Also, continuing on part of our partnership with our foundation, we want to also just recognize that we were able to unveil our first set of murals across our organization, connecting people with health and art. Our mural unveilings, several Cook County Health locations are shining a little brighter after the new murals were unveiled at Providence Hospital, Blue Island Health Center, and Professional Building on our central campus. The Community Murals Project, a partnership between Cook County Health and our Cook County Health Foundation, used a collaborative mural making process as a tool to build trust and engagement between our healthcare sites and our communities, to build neighborhood pride, and to create beautiful spaces for healing. There were paint parties were held where patients, staff, and visitors could come together for our murals. These are 3 mural installations, and when they were created, our actual medical staff, our community advisory councils, and our PFAC, our patient family advisory councils, were all talking to the artists, and then we all got to paint. So not only was it a beautiful way to create art, it's art in itself that we got to actually participate and to be able to share in the building of it. And you see some wonderful things that were encapsulated. Blue Island really showcases the amazing elements and history of Blue Island and where it comes from. Providence, the mural is incredibly powerful on the history as being the first African-American owned and operated hospital in the United States, built, and what it has done in the community. And then the Strozier facility really shows the compassion and caring and impact that we have, not just for our staff, our patients, but overall to the community. And so those were elements that were each gathered from the conversations that the artists have, and we're very proud to have them. They are beautiful works. We encourage everyone to come in. And so we think that they do inspire a little bit of connection with our facility, as well as being able to provide some peace of mind and healing environments when people come in. And so we're very thankful to the Cook County Health Foundation for sponsoring this project, and for all of our staff and the artists who help to bring these works of life to art. And please come out and see them. They are very beautiful if you've not had a chance. Questions? The next slide. We also want to have a reminder that we have redetermination is upon us. We are in the process of starting to have all individuals who are on Medicaid redetermined. Because of the public health emergency, there had not been redetermination for some time. And so we want to remind everyone that our redetermination materials for anyone who wants to get information is available at cookcountyhealth.org. /redetermination. In there, you will be able to see robust member education efforts that we're doing to share redetermination materials with patients and communities. We're going to be doing this throughout Cook County Health, through our partners and providers, with each encounter that we have with patients. We're going to be working with our social workers and our financial counselors to remind patients about the redetermination process. We are working with community-based organizations. We have shared the information with elected officials. We are having redetermination events throughout our Cook County Health Centers to be able to get out information. We're having community engagement events with partners at all the locations that we can get to. And we have organic and paid media outposts that are being put all over across our media spectrum. And we have other traditional forms of media outreach and advertisement as well, to make sure that everyone has their information. As you can see, there is a frequently asked questions document for Medicaid members. It's in English, Spanish, Polish, and a few other languages that you can see represented there. I don't want to misname the languages that are there, but they are put in their scripts. So they're available in the 7 most predominant spoken languages to our patients. We also have a frequently asked questions document for FQHCs and providers, and then we have redetermination flyers that people can use to post on social media, other posts, to encourage people to get all the information that they need to as they go through this redetermination process. And I'll tell anyone who's Medicaid eligible now, what you can do now is that you can make sure that you've gone to the state webpage and that you have updated your address and your current contact information, and that you keep an eye out for that redetermination paperwork. And if you have any questions, you can come to our website, or you can simply come into our health center, and we will be able to help you with any information that you need. Any questions on that? All right. Lastly, we also want to highlight Senator Duckworth's visit. Strozier Hospital welcomed Senator Tammy Duckworth on Monday, April 24th, to highlight the nearly $900,000 in congressionally directed spending funds that were given and were secured by the senator for Cook County Health. The funding will be used to purchase new state-of-the-art incubators and infant warmers for the hospital's neonatal intensive care unit. And also, we want to just be able to share that our Building Healthier Communities Q1 report with the board. We have $4 million in awards to 23 community-based organizations that are serving suburban Cook County. 42,363 participants or people have been served in total. There you can see the breakdown of individuals and where those are. The food insecurity has served 40,000 individuals. Positive youth development was 590 individuals, and mental health was 777 individuals that have been served. The Cook County Department of Public Health's suburban Q1 grant results were 288,342 meals that were served, distributed, or delivered, 1,041 referrals to nutritional assistants, and 110 mental health service referrals. And so this shows you a little bit of our impact that we are starting to do with our Building Healthy Communities grant that was funded through our ARPA partnership with the county. We also want to be able to share that we have $1 million in awards to 13 community-based organizations in Chicago. So we funded both the suburban district and the Cook County Health Systems partnership with ARPA. We were able to give residents within the city. That has served 3,584 participants that have been served. And there you can see the breakdown: 777 in mental health, 40,996, pardon, a little tongue tied this morning, with food security, and our positive youth development 590. For Cook County Health Chicago 1 grants, you can see that that translated to 18,401 meals that were served, distributed, and delivered, 55 referrals to our federal nutrition assistance programs, and 160 referrals to mental health services on the city jurisdiction side. Also, we want to have a reminder that we're going to have an end of COVID-19 public health emergency. So to tell us a little bit about how this impacted our system, what our system's operations will change, I'm happy to bring forward Craig Williams, Dr. Sharon Welbel, and Eliana Moore.
Good morning. Thank you. With the end of the public health emergency from HHS and CDC, I do want to talk about an update of our COVID epidemiology. So this is data from the Centers for Disease Control and Prevention. And from here, you can see that cases, finally deaths, and hospitalizations are all decreasing. However, only 16.7% of the US population has been vaccinated with the bivalent vaccine. I do want to mention, when people talk about cases, or when this type of data is mentioning cases, this is really no longer a reliable measure of disease activity, because the only reported cases are those performed with the nucleic acid amplification test, such as a PCR. And as we know, most people are currently doing a rapid antigen test at home, and those are not included in this case count. Next slide, please. So this is another slide from data from the Centers for Disease Control and Prevention, and they provide us with some modeling on what are the most prevalent variants in the US. And currently, as we know, it is XBB 1.5, which is over 70% of the variants. But there are always emerging variants, which is why we need to be resilient with our mitigation measures. Next slide. So what we are seeing now is there's a new variant of interest, and actually based on WHO, CDC, and a number of other organizations, we talk about variants of concern, variants of interest, and there are other categories of variants. This is called a variant of interest, where we're not necessarily saying that we have to change public health measures now, like we might do with a variant of concern. However, we do see that it is now 9.6% of the US isolates and 1.77% of the Illinois isolates. This, again, has a growth advantage over the previous circulating variants, and it also has the ability to evade the immune system. It was first detected in India this year in January, and it did result in a significant COVID surge. So again, we need to be resilient. We may see these variants that can cause another surge, and we might have to change our mitigation practices. Did somebody have a question?
Director Wellville, this is
Yeah.
the chair. I just want to acknowledge that before we get too far, Director Harrington has his hand raised and has a question.
Oh, sorry, go ahead.
Yeah, I have a very quick question. When you indicated the total number of infections, I assume that does not include people that were reinfected, because I know a number of people that have been infected 2 or 3 times.
It might, it certainly might. Cases are just cases, any reported cases. And I don't believe that they are deleting reinfections, sorting by duplicate names and so forth. Right. But again, not really a great reliable measure of disease activity. One thing that I can say about that measurement is that since we do universal testing of patients who are admitted to our hospitals, we have always known our own test positivity rate. And since we started doing that, it has always matched very closely with the test positivity rate of the city. So I use that test positivity rate still today. And what it is today is about 4%. And just to give you some background of that, a year ago, it was 1%. So even though we talk about the end of the public health emergency, it is not the end of the pandemic. We just need to learn how to live with this pathogen as it has become endemic. But as I'm showing you, we do continue to have emergent variants. So we are actually at a higher level now than we were a year ago. Next slide. So with masking continues to be strongly recommended for all individuals in all of our facilities. And that's because they've been shown to significantly reduce transmission of COVID-19, as well as other respiratory viral diseases. Wearing a mask can help protect yourself and others, including our high-risk patients and our colleagues from, again, these respiratory illnesses, and not just viral respiratory illnesses, but tuberculosis and other. So we have decided to go to requiring masks as part of standard, or what used to be called universal precautions, and I'll talk about that more in the next slide. But if a patient does have any other precautions that require different transmission-based precautions, such as COVID, contact, or airborne, those will also have to be followed, of course. Next slide. So effective Monday, May 15th, masks will be strongly recommended, but optional for many of our patients, staff, and visitors. Sorry, just to enlarge my screen so I can read this. So masks remain required for team members who are providing direct patient care or are entering an occupied patient room. So what does this mean? This includes, but is not limited to, performing a physical exam, having a conversation with a patient in their room, taking vitals, transporting a patient, cleaning a patient's room while the patient is in the room, delivering a dietary tray. Basically, anytime one would clean their hands prior to seeing a patient, that's what's called standard precautions. And using any other precautions that are necessary, it is now going to be required that one continues to wear their mask during those activities. An occupied patient room includes an ambulatory exam room, a hospital room, or a curtained bay. All team members, patients, and visitors do have to remain masked in high-risk areas. So this is not just in the patient room, but it's in the entire area. So that's the emergency department, because there's largely bays there, and because we know people come there because they are sick. So they may be immunocompromised, or they may have a viral respiratory tract infection that we want to prevent the transmission of. Other high-risk areas are hematology oncology clinics, our radiation oncology clinic, our infusion center, and our neonatal intensive care unit, because again, that is largely an open bay. Visitors in patient rooms are also going to be required to wear a procedure mask to protect our patients and themselves. And where does that recommendation come from? When we have looked at the epidemiology of hospital-acquired COVID, it is almost uniformly been caused by patient visitors. So persons must be masked also when in conference rooms that are at maximum capacity. We've gotten really used to knowing the capacity of rooms. That's a fire code definition. But when those rooms are being used at capacity, people are so close to one another that we want them to be masked. And then my team may require masks for other large-scale events, such as those where closed interactions are possible. And then, of course, if a patient asks a team member to wear a mask where they're currently not required to, or as of May 15, we do, of course, ask that the staff respect that request. And I'm going to move it on to Craig, and always happy to answer any questions.
Thank you, Sharon. This is Craig Williams, Interim Chief Administrative Officer. Just some of the other mitigation and changes that will take effect on Monday, May 15th. Oh, do we have a question from Director Harrington?
Yeah, this is a quick question. Are the areas where masks are required, is there gonna be signage there making it clear that masks are required?
Yeah, yes, our communications team has been working for some time already on this signage, messaging, and so forth.
Thank you.
Is there another question from Director Story?
Quick question also. As I listen to the places and the circumstances under which an individual patient, and particularly in the patient area, but visitors and team members at CCH have to wear a mask, it seems to be pervasive. I don't know how you can have signage, because like there's so many circumstances in which your team members will be in a space with a patient or visitor that requires masking. I don't know how you police that. It just seems like the status quo should remain the status quo, in my opinion.
Director Story, are you saying that the status quo is universal masking?
Yes, ma'am.
Yeah, that is, I'm never against more protection. But again, while we're learning to live with this endemic pathogen, I think we need to understand and compromise in terms of allowing healthcare providers, visitors, and patients a little more liberty and relaxation from the mask while still protecting our patients. And so, as I said, just like when you go into a room and you clean your hands or you put on gloves, you'll be putting a mask on. If one takes vital signs, they will be wearing a mask, but outside of patient rooms. So it'll essentially be when healthcare workers are together. And of course, if a healthcare worker is has symptoms consistent with a respiratory viral illness, we ask that they not come to work, and that's very important, and we do emphasize that. We want to get rid of presenteeism, but that's where people will have a little bit of relaxation from masking. I'll say that there was a report of a hospital in California that went to mask optional, and of course this is mask optional. So, and anybody who wants to wear a mask, and we are strongly encouraging universal masking. There was a hospital that went to completely mask optional. You didn't have to wear them at any time if one didn't want to. That was for healthcare workers, visitors, and patients. They did have an outbreak of COVID shortly after they did that, but their mitigation was to go to what we are currently doing now. But I hear you, and I understand that, and that's why I'm saying we need to be resilient, and we may have to go back to universal masking. I think of the Chicago hospitals, we remain one of the strictest, if not the strictest. Most are just doing mask optional. University of Illinois and University of Chicago are still figuring out what their strategy is going to be.
Okay, moving forward. So just some of the changes that will also take effect on Monday, May 15th. Our patients and visitors will be screened for flu-like illnesses at registration. That's an OSHA requirement. However, we have a workflow within Cerner that supports that documentation. However, persons entering our facilities will no longer be required to do a temperature scan at the front entrance. We'll continue to provide masks at all entrances to our clinical facilities. And our sites may remove the plexiglass barriers around registration areas, but we'll leave that up to individual colleague preference. Our hospital visiting policies will be relaxed to pre-pandemic policies, so there'll be less limitations on visitors to patients who are inpatient, and we'll once again be allowing food and beverages. We have an entire signage plan that not only includes hanging up new signage, which will educate patients and visitors about the changes that are taking place. We're also going through a process of taking down signs that no longer apply, just to make sure that there's not confusion as people are entering. And next, I'll hand it off to Ileana.
Yes, good morning. Oh, sorry. It does look like two other people have their hands raised.
Yes.
Yeah, I have my hand up. I just wanted to comment. This is Director Ryder. I just wanted to comment that, I think that having a balanced approach as this becomes an endemic situation is the correct one that, especially with the training that healthcare workers have on masks and the way that we utilize masks in a hospital setting where we get fit tested and everything else. That we're using the appropriate level of masking, that, if someone does not feel comfortable in one of those settings outside where it is mask optional, that the masking, the person putting the mask on is protected, not completely, but largely from everyone around them. So I do think that making sure that we're masking at the appropriate times where we're in crowded places or where we're taking care of patients, we're in close proximity. It does sound like we're following where the science is at on masking, especially considering that healthcare facilities are the best trained and best equipped to use masking. So I think it's great that you guys are holding a high standard, but also figuring out how to work in this new environment, because there are times where social distancing and everything else is happening in places away where colleagues are working with each other and they know how to gauge what their protection is. So as someone who as someone who makes his own personal observations of when to put the mask on and making sure that I have one available, I understand the nuance that you guys are trying to work on in balance, because I'm also, I identify, personally, I identify those situations for myself all the time.
Thank you, Director. And of course, we do continue to monitor all of our COVID test positivity rates, every infection and so forth. So we will have the information ready in the event that we do need to pivot to different mitigation practices.
I won't get in my car with my own children without a properly fitting KN95 or N95 mask if they even so much as sneeze before we get in the car.
That's a good practice. Other questions?
Yes, thank you. If you don't mind, I'd had my hand up for some time, but thank you. In following up with what Director Story had noted, I actually work with a group of those that are experiencing long COVID, and I think it's going to be important to recognize that, sadly, once again, we're placing those that might now be with disabilities at the onus of having to self-advocate in a system that sadly isn't frequently as conducive to being able to do that. In looking at your methods for allowing patients to opt in to masking, you might consider how that can be part of the initial triage discussion, or a question that can be asked, so that we're empowering patients to feel comfortable self-advocating for masking should they request that. Otherwise, if each time a medical professional enters the room and a patient is then being, in this sense, put upon to ask them to mask, that's a large ask for the patient. If we can have a way to identify potentially as part of the intake process, would you prefer that medical encounters go forward with you with masking? We're actually encouraging them to be able to speak forth for their own health or safety in these contexts. Thank you.
Oh, yes, thank you. That's such an excellent point. So in fact, it is required that when anybody enters a room, or even outside of a room when somebody's getting their vitals done, that the healthcare worker has a mask on. All persons entering the hospital will be offered a mask in terms of visitors, and then patients will also have access to masks. So masking will be required for all direct patient contact. I hope
This
that
is
helps.
directed. This is Director Harrington. I really want to pick up on what Director Ryder said. I think that what we're doing is appropriate based upon where we are now in terms of the pandemic becoming endemic. And there was a term that was raised, presenteeism, which I know, and I don't know if everyone knows what that is, but it caused me to wonder whether or not we have any measures of that currently. And if we don't, how will we know if it increases?
Yeah, that's a really good point, because that's really, we educate people in our messaging, in annual education and so forth over and over again. And this includes pre-pandemic, trying to prevent, particularly during the respiratory viral season, transmission of respiratory viruses among healthcare workers, patients, visitors, and so forth. So it's really just educating healthcare workers to attest that they do feel well, that they don't think that they have a transmissible disease when they come to work. But to your point, there's no practical way that I'm aware of, or that anybody else is doing to, to really confirm this. It really just, we are just advocating. It's such a difficult field, when I think whenever healthcare workers at any level says, I'm going to stay home today because I have the sniffles, they're thinking, who's going to cover me? And so I think folks who work in the health industry feel like, I have to come to work. And I'm not just talking about nurses or physicians, but I'm sure people in all the other services, dietary, environmental, are, may feel this way as well. And that's what I think as a culture, we need to make sure that people feel like there is somebody who can cover for you. It's healthier for the institution not to come and transmit disease than to come and transmit disease, particularly since it will no longer be universal masking.
I agree, and I think that it's sort of implied that maybe there also needs to be some messaging about, things like if you're sick and maybe this seems like a minor cold, maybe you shouldn't come to work because you can infect everybody else in the office.
Yeah, no, absolutely. And we actually have been doing that even again pre-COVID. But we can emphasize that even more. Thank you. I appreciate the comment.
All right, good morning. I wanted to give you an update on how this impacts vaccinations and testing. As you all know, Cook County has played a critical role in vaccinating county residents. We vaccinated over 1 million, we've provided over 1 million doses and tests as well. We've been a big, provide a lot of access as it relates to testing. We, going forward after the public health emergency, we will be integrating the vaccination efforts and the testing with our staff in the primary care medical homes as a result of the reduced funding and the cost of vaccines and the test. We will be making sure that we collect insurance and process vaccinations and the tests as well as we would have done had it not been a public health emergency. So that will resume and begin. The Stroger Hospital Vaccination Clinic and the testing tent will remain open for the community at large and of course for our own patients and staff. However, our own patients will be able to receive vaccinations and testings at any one of our primary care medical homes. And of course, anyone that may come in from the community seeking a vaccination, regardless of whether or not they're our patient or not, will always be welcomed in any one of our primary care medical homes. But the Stroger Hospital will certainly remain open and advertised as being open for the public. That summarizes some of the changes relevant to vaccine and testing.
Do we have any additional questions, directors? Not. Thank you very much for the update. Mr. Rocha,
Thank you, Chairman.
Any further?
No, that's it. Just I submit our full report for the board. Thank you.
Thank you very much for the very thorough report. Appreciate it. Next, Dr. Hasbrook and Dr. Joshi will provide an overview of the proposed CCDPH 3-year strategic plan being presented to the board for its consideration. Dr. Hasbrook, Dr. Joshi.
Yes, good morning, Chair Taylor and directors and colleagues. So Lamar Hasbrook, Chief Operating Officer for Cook County Department of Public Health. And I'm going to introduce our speaker, who you all know, Dr. Karen Joshi, to walk through our strategic plan. Just want to give a little prelude to say that our last strategic plan expired at the end of the calendar year. We started working on this in October, so we've been working in earnest for about 6 months on this plan. We're very excited to present it, very proud of it. And I want to say that in addition to working hard, we've been working very smart. So leveraging things that we've done in the past, surveys, internal, external engagement with communities, et cetera, which you'll learn a little bit about. So I just wanted to put that into context and tell you that everything we're doing is really grounded in our commitment to build healthier communities by sustained and authentic engagement with the communities. And so we call it putting the public in public health. And with that, I'll turn it over to Dr. Joshi. Karen, take it away.
You're on mute. Dr. Joseph.
We can see the
can't hear
slides.
you.
We can't hear you.
You're still on mute.
Can folks hear me?
We can hear you
Yes,
now.
we can.
Thank you, sir.
Great. Apologies for that. All right. So I'm here to talk with you this morning about our strategic plan, which was a very thorough process, but an expedited process nonetheless. So you can see some lovely photos here of our staff, of Dr. Hasbrook, and of one of our community listening sessions. We held two, both of which were very well attended and I would say successful. Just a quick photo here, screen grab of the cover of our plan. All of you should have received a text-only version during the public comment period that we held, which started a couple of weeks ago, and then a fully designed version of the plan earlier this week. So as I mentioned, thorough but expedited. We started this process in October with the intention to work smarter but not harder, and also to minimize any sort of burdensome data collection by looking at existing data, existing assessments, and trying to extract from that as much information that we could, so then we could really thoughtfully collect any additional data to fill the gaps. You can see that we began with a crosswalk, spent some time in November talking about what data we actually did need to collect, held an all-staff retreat at the time. We held an advisory group meeting, a series of advisory group meetings starting in December with leadership from CCDPH, and thereafter followed that up with a number of sessions with leadership, including just informal coffees and one-on-one interviews. By January, we were ready to define the pillars of the strategic plan. I'll speak to those shortly. Completed the data collection in Feb, held a leadership retreat in Feb. In March, held some community listening sessions, having finalized the pillars and most of our strategies, went through an extensive internal and external review process, including the public comment period that I mentioned, all to bring us to this meeting, where I will get right into a little bit more of our process. So as I mentioned, a lot of engagement here with staff, and we engaged with our own staff, our own leadership, but also looked at the outside world, including plans from other agencies, plans and assessments that entities that we had worked with had developed for us. You see some examples of those here on the right side of the screen, notably an after-action report, sort of a comprehensive global after-action report that we've conducted for our COVID response. We also looked at plans from Cook County government, including the President's Cook County Policy Roadmap, our very own CCH strategic plan, and of course, our own Community Health Improvement Plan, We Plan 2025, which is the Community Health Improvement Plan for suburban Cook County. And you can kind of see here on this graphic where there's overlap and alignment between the various pillars of our plan and the three plans that I mentioned. Okay. In terms of feedback, I mentioned that we took this under Dr. Hasbrook's leadership very seriously. Held two sessions, one in Maywood and one in Oak Lawn, targeting our north and west suburban communities and south and southwest suburban communities respectively. Had more than 50 attendees, a lot of enthusiasm, a lot of participation. Followed that up with a staff survey, had a number of responses and comments. And then I mentioned the public comment period here. We've had a lot of engagement on our social media around this, as well as many, many hits. I want to say like around 7,000 page views for our website. So this brings me to really the heart of this presentation and a graphic that we're going to be using to communicate about our plan. Of course, at the top is the vision, which is that we want all people in suburban Cook County to realize their full health potential, regardless of who they are, where they're from, or where they live. Our mission is codified in Cook County ordinance and remains the same as previously. And I just want to highlight here that I'm really proud to work for an agency that really centers the idea of health equity. We live this concept in our work, and it's integrated into everything we do. So we have 7 pillars here. You'll see that there are 5 that hold up the strategic planning house, and 2 at the bottom that are sort of undergirding pillars that are also cross-cutting. So just speaking to those, as I mentioned, racial and health equity is central for us. And then, of course, we need the funding and the resources to do what we do. So also really crucial there. So pillar 1, strategic communications, community partnerships, pillar 3, workforce, and I can't see pillar 4. Infrastructure and operations, and then integration and systems alignment. So I'm going to dive in now to each of those, starting with strategic communications, and wanted to make the point here that we're not just focused externally, also internally, because we want to be as transparent and collaborative with our own staff as possible to create a culture of trust. And then, you know, with that trust, of course, as I've heard Dr. Hasbrook and you all say, like, we want to have a culture of accountability as well. Of course, we want to have external communications as well. Should go without saying that we want to be that trusted voice in the community for public health, and thus want to amplify our own public presence and visibility. The next pillar is community partnerships and collaboration. So this is closely intertwined with external communication, but somewhat separate. This is more about partnerships with all kinds of entities, the richness of entities across suburban Cook County. And so we want to diversify that. We want to be plugged into the community because we want to know, first and foremost. We want to be sensing what's happening. We want to elevate the community voice to inform our own work. And then, of course, I think it's critical to have strong community partnerships because we work with community partners very closely to really do the work of public health on the ground. So what do I mean by that? One really concrete example is that we held thousands of mobile vaccination clinics across suburban Cook County, but that couldn't have happened if we didn't have community partners on the ground that reached out to us and said, hey, you know, I'm a pastor at a church that wants a clinic, or hey, I work for an immigrant rights organization in the west suburbs, and I'd really like to host a clinic. And so working together, we were able to get thousands and thousands of people vaccinated. So next up, workforce and workplace. Again, sort of goes without saying that our staff, our workforce is one of our most valuable resources. And so here we really want to support them. This is going to include everything from looking at how we recruit and hiring practices. We want to make sure that we're equitable there. So I want to flag this as a way that health equity sort of cross-cutting pillar intersects with one of our vertical pillars. Of course, we want to do the critical work of updating our job descriptions, looking at a pipeline into the public health workforce. I think CCH has done some wonderful work in just that. So we would love to amplify that, expand it, and we look forward to partnering to explore ways to do that in the near future. And I want to just flag.
Yeah. Don't mean to interrupt, but I just want to highlight Director Harrington's hands up. So I'm not sure I know you're going through, but before you get too far with a question.
Sure. Happy to take questions at any time.
Yeah, I appreciate the opportunity to ask a question. If you could go back one slide, I think it was on pillar 2. Yeah, and I'm really interested in hearing a little bit more about how you plan to formalize and coordinate partner relationships. I guess that some of that is informal right now. So you're not talking about agreements, or Because I think that's a good direction to go in. I was just wondering what you might have in mind relative to that. Thank you.
Yeah. So go ahead, Dr. Hasbrook. I'm not sure if you're going to comment.
No, you can take the first swing at it. I'll add to.
Okay, sure. In my mind, this is closely connected to bullet 4 in data infrastructure, because we really need, I think, some tools in our agency, given the breadth of suburban Cook County with over 2.4 million people, 125 municipalities, and really countless partners, to get a handle on who those partners are and how across our agency of over 150 staff, how we're connecting with those partners so we can have some visibility into that and potentially coordinate. So I think that's probably like a good second or third step, I would say. But then looking down the line, depending on the relationship, the public health need and the strategy, there may be a need for some sort of more formalized relationship that could be memorialized in some sort of legal agreement. But I don't have a specific example for that at this time.
Yeah, thank you, Dr. I'll just piggyback to that. So it will be more codified and formalized before it's contractual in terms of more of a community advisory board, some regional learning action networks, working with our grantees. We got about 50 of them out there now with the Building Healthier Communities, either the mental health track or the other track. We realize that we are out in the community often and we're making these relationships. So we're trying to codify this in a more regional approach. In addition, we do have a team that's dedicated to this. It's called the Community Engagement and Health Education Team. So they're already assigned kind of in a regional way. So they have these very, very rich relationships with the faith-based organization, community-based organization, et cetera. So we're putting together the master scheme on how we can kind of move forward and make sure that's sustainable and get on a cadence where we're meeting with them on a regular basis. So a lot of work in this area.
I would imagine so, and I want to applaud you for actually recognizing that this is something that's important and needed.
Thank you.
Thank you, Director Harrington, for your question. Right, I'm going to go back to so pillar 3. I want to flag here for you all item 6 because it's a really, I think, beautiful collaboration between folks at CCDPH and other departments across our health system. We've been working to advance trauma-informed care. We would love for CCH to be a trauma-informed institution. And I'm really pleased to say that this is an initiative that came out of both a prior CCH strategic plan and has really bubbled up from a small group of highly activated staff. So it's really been a labor of love for some wonderful staff. And I look forward to myself or Dr. Hasbrook coming back and briefing you on some of the outcomes of that. So moving on to infrastructure and operations. So look, we all know that this may not be the sexiest pillar, but I would argue that it's a really critical pillar. I think during the pandemic, there were many sort of administrative hurdles that we encountered. And so the way I'd like to frame this is this idea of administrative preparedness. So if we ever have public health emergencies or anywhere near the scale of COVID, again, we want to be ready to do things like contracting quickly, hiring quickly. And so this requires that we have some infrastructure within CCDPH to support existing administrative processes. And just want to sort of express my thanks for partners in CCH HR, supply chain, and finance for working with us as we try to build out our own administrative capacity to interface with existing CCH administrative support areas. And then this also connects to the next pillar, pillar 5. We want that integration, and we're wanting to be very intentional about that integration, not only administratively, but potentially strategically as well. So I mentioned the trauma informed care initiative, again, something that I feel really good about, and I think everyone should. There are also other areas that are, I think, ripe for collaboration. We're at the table when there are conversations going on about violence prevention or harm reduction, about opioid overdose prevention, and maternal and child health. And I think a lot of good work could potentially come from that. So intentionally including this pillar to flag for us the need to continue some of the good work that's already been happening, again, between CCDPH and various CCH departments. So in conclusion, I find myself here in April, looking forward. We're planning to present this plan to the Cook County Board of Commissioners in June. And then move on, something we're already doing and thinking about, which is implementation. We're not interested in having a plan that sits on a shelf. We want something that is going to be actionable, acted on, and help us really drive strategies. So we're fortunate enough to have a manager of quality improvement and accreditation who's been tasked with managing the performance management system that we're building around this plan. Including, to use one of Dr. Hasbrook's phrase, metrics that matter, as well as holding ourselves accountable to the community. So we're planning to do quarterly community updates in which we're going to be rotating through our various, through our 4 regions, North, West, Southwest, and South. So I think that concludes my comments. I'm happy to take questions. Before I open it up to questions, I wanted to take a moment once again to thank Dr. Hasbrook for his leadership here, Mr. Rocha and colleagues at CCH that provided feedback. And most importantly, I wanted to take a moment to thank all of our staff, many of whom provided feedback to this plan, and in particular, the very intrepid Hannah Kite, CCDPH Regional Health Officer, who really was the driving force behind this plan. Thanks, Hannah.
Director Bott, I think we have a question. Yes, Director Bott, or comment.
Thank you, Chairman Taylor, Dr. Joshi, and Dr. Hasbrook and team. Tremendous work. It's great to see this. One thing that didn't jump out, but I'm sure is incorporated into this, is opportunities to innovate around public health functions and be a pioneer in the context that CCDPH operates. How are you seeing that play out across those pillars? Driving innovation on redesigning public health functions so that they're more efficient, effective, and cutting edge.
Thanks. Great question. So a couple of things, and yes, it is embedded in the report. We talk about Public Health 3.0, which I'm sure you're very familiar with. We talk about the chief community health strategist. So those are things we're building on. We see ourselves in a great position being in the CCH family as an affiliate and availing ourselves of the other departments and things like that. So I really see some connectivity, not only with CIRMAC and some of the things they're doing through innovation around data mining, some of the things we're doing with our health portal that we have, but also with county cares as well. So I've been in talks with Dr. Collins, because again, that's another 450,000 folks that we feel like we have a lot of overlap there. And again, if it's data, if it's programming, we want to repurpose the things we're doing so we can get the most mileage out of it. So there is that piece. I think it probably comes under the pillar of integration, because we see our greatest strength as being in the family of CCH and really working collaboratively and more integratively with the other existing, let's call it service lines or other departments.
Great, and I'll send your way a new initiative that Kaiser Permanente launched with 3 pillars, one with the associations, AHIP, AHA, and AMA, and then another's with CDC and with Academy Health around public health, healthcare delivery, CBO integration, which speaks to that last pillar and might be helpful resources there.
Excellent. Thank you. There's no more questions.
Do we have any further?
Yeah. Oh, sorry, Chair.
No, please go forward.
I was just gonna say, if there's no more questions, thank you all. It's not too late to get your input in. We have not taken this to the printers yet, and so we are awaiting your approval and obviously want to get the feedback from the commissioners. But again, I want to thank our staff. We actually had a strategic planning advisory committee internal, about 16 folks. Want to thank them, and of course, Dr. Joshi for leading our efforts. So thank you all.
Thanks both of you for the very comprehensive report, and to your point, a very well thought out strategic plan. Look forward to working with you going forward to actually execute it.
Thank you so much.
Next, thank you. Next, going a little bit out of order here, I'd like to just have my report, which will be very brief. This month, we confirmed committee assignments for the newer directors. They as follows. Director Bott will serve on the Quality Patient Safety Committee. Director Robinson will serve on the Finance and HR committees. Director Sorrell will serve on the Quality Patient Safety and HR committees. And Director Webster Cross will serve on the Quality Patient Safety and Managed Care committees. Because we had some additional members added to the QPS, Quality Patient Safety Committee, Director Story accepted a committee assignment change from the QPS committee. He'll now serve on the Managed Care committee and remain on the Finance Committee. So I want to thank all the directors. Welcome new directors, and thank you all for your service, both on the broader board and work in the committees as well. At this point, I would like to entertain, I think we're ready for the combined motion, I believe. Just to clarify, if there are no other questions, I want to make sure we don't have any. If there are any questions on the committee, on the minutes and the actions being presented for consideration, if there are none, we can move on to the combined motion. So before I do this, I want to make sure we have any other questions or comments. Hearing none, great. I'd like to entertain the following combined motion to approve the following. Item 4A, March 31st, board meeting minutes. Item 4C, April 21st minutes of the Audit and Compliance Committee meeting, which include the 2023 County Care Compliance Plan, 2023 County Care Fraud, Waste, and Abuse Plan, and the proposed internal audit charter. Item 4D, April 21st minutes of the Managed Care Committee meeting. Item 4E, April 20th minutes of the Quality and Patient Safety Committee meeting, which include the Stroger and Providence Hospital medical staff appointments, reappointments, changes, and the proposed clinical training affiliation agreements. Item 4F, April 20th minutes of the Finance Committee meeting, which include contracts and procurement items and the grant award related items. And item 5B, proposed CCDPH 3-year strategic plan for 2023 to 2025. Do I have a motion?
So moved, Director Harrington.
Thank you.
Second, Director Curry.
Thank you. The combined motion has been made and seconded. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Bott?
Aye.
Director Curry?
Aye.
Vice Chair Deere is absent. Director Garza?
Aye.
Director Harrington?
Aye.
Director Kim?
Aye.
Director Ryder? Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell?
Aye.
Director Story?
Aye.
Director Webster Cross?
Yay, with the exception of contract and procurement requests, numbers 1 through 21 contained with items 4F, April 20 Finance Committee meeting minutes, for which I vote present.
Thank you. And Chair Taylor?
Aye.
So you have 11 yays and 1 absent, notwithstanding Director Webster Cross's present vote on request numbers 1 through 21 under the Finance Committee minutes.
Thank you. The ayes have it. The combined motion carries. Thank you. The board will now be going into closed session. Action is not expected to be taken in the open session after discussion in the closed session. I'd like to entertain a motion to go into the closed meeting pursuant to the following exceptions to the Open Meetings Act 5 Illinois ILCS 120-2 C1, 2, 11, 12, 17, and 29. Do I have a motion?
So moved, Director Harrington.
Second.
So Director Bott. Thank you. The motion has been made and seconded. Madam Secretary, please take a roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay, Director Bott?
Aye.
Director Curry?
Aye.
Vice Chair Deere is absent. Director Garza?
Aye.
Director Harrington?
Aye.
Director Kim?
Aye.
Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell?
Aye.
Director Story?
Aye.
Director Webster Cross?
Aye.
And Chair Taylor?
Aye.
You have 11 yeas and 1 absent.
Thank you. The ayes have it. Motion carries. Directors, please join me in a closed session. Thank you.